multi-dimensional research platform, so we ended up collecting a lot of different information. And I think in the next sessions, we would provide you how you will get an understanding in greater detail on what are the modules and how they can be used in data analysis. But just to give you a brief overview, so basic information on demographics, education, household income, then contact information for tracking, for longitudinal tracking was collected, behavioral data, alcohol and tobacco use, diet, physical activity. Then of course main purpose of this survey was to look at non-communicable diseases, so the past medical history, family history, and the different non-communicable diseases. We had modules on physical, mental health, functioning, activities of daily living, and instrumental activities of daily living. We have a module on long-term care, medicines use, which I will discuss a little bit in more detail later. Employment and work, healthcare use, both inpatient and outside. What is the reason for encounter, the provider, expenses, insurance coverage, and so on. We also assessed awareness, knowledge, and use of the Ministry of Health, healthy lifestyle clinics. We had a module on cognition, health service perceptions, sleep quality, and then of course the salt intake for the salt intake questions for the 24-hour sodium excretion study of the MRI. So the relevant modules were developed in order to compare with other international surveys like the Health and Retirement Study, WHO STEPS, EU SHARE, ENHANCE, and so on. Then examination, we collected anthropometrics, height, weight, waist circumference and hip circumference, test, blood pressure, spirometry, ECG, body composition, fat, lean mass and water, grip strength to assess trends in aging, also gait, and then lab tests on fasting blood glucose, OGTT, HbA1c in a subsample because the test is really expensive, lipid profile, creatinine, and a few others. So I would like to mention 3 SLHAS innovations. There are a few more, but I'm focusing in this presentation on just 3. One thing is we wanted to collect information on medicines use, and this is something that few other even international surveys have had trouble doing because collecting information on medicines is very difficult because they are given, there can be lots of errors in data entry, different people will write different medicines in different ways and so on. So we wanted to develop a system where we can rapidly enter and code the medicines on iPads. So how did we do this? From the databases that were available to IHP, we developed at that time a full list of all the medicines, generics and brand names, and then we input this into the CAPI system. So the field teams simply had to just type in a few words and you would get the whether it's a brand or a generic, the relevant medicine would come up, so they will simply have to select, and once they select the medicine, only the dose that is relevant to the medicine will show up in the next one. So in this way we were able to quickly enter medicines data into the CAPI platform. So we collected information on brand name, generic name, dose, frequency, what is the reason for use, and then we also had some questions on compliance, prescriber, whether they were prescribed from the government or private sector, whether they bought the medicines privately or did they get the medicines from the government sector, and if they were going to the government sector but bought the medicines from the private sector, we would ask for what are the reasons that they did so. And then later on we can also process it back and assign WHO ATC codes to the medicines for further analysis. I think the work that is presented in the next session will provide you more details regarding this. And then for lung function, spirometry, we use the Nouveau Air spirometer, which is EU approved medical device, and it was approved by the NMRA for research purposes. The spirometry using iPad compatible spirometers allowed us to check and report on the test adequacy in real time, and the data was transmitted via the cloud to the office. And then we, for ECG, we used the Cardio Secure Mobile, again a EU approved medical device, which was again NMRA approved for research use. So this actually takes an ECG, which is, but using only 4 leads, but it can give an output that is comparable to a 12-lead medical device, medical grade ECG. So that's a brief overview of wave 1, and as Dr. Ravi already mentioned, around 99% of wave 1 participants gave consent for long-term tracking, so which allowed us to do the subsequent surveys using computer-assisted telephone interviews, the CATI utilizing the wave 1 cohort. So just briefly on wave 2 and wave 2X. So wave 2 was conducted from October 2021 to November 2022. And this was during COVID, so for high-frequency tracking of the impact of the pandemic, along with the core modules that was relevant to the longitudinal tracking of the SLHAS cohort. And in wave 2X, this was extended in continuous basis because of the ongoing economic crisis in order to track the impact of the economic crisis on people and health. So how was this done? The wave 1 cohort was randomized to 5 subsamples. So each sample at any given time interval, say a week or a month, was approximately nationally representative. And data analysis adopted an iterative proportional fitting method as the default weighting procedure to ensure national representativeness. Data collection, of course, the core modules for longitudinal tracking, so the socio-demographics, the economic status, work and retirement, NCD history, healthcare access, utilization and spending, and psychosocial factors. Then of course, depending on the time of data collection, whether it's COVID or the economic crisis, we would include, it's flexible enough to accommodate the inclusion of additional modules to track the impact on people's health. So we have now established the wave 1 cohort. So one of the questions that you might have is whether this cohort is contactable and whether it's feasible to do longitudinal follow-up. So the wave 2 and wave 2X showed that these waves attempted to contact more than 95% or almost 97% of the original wave 1 cohort, and these are individuals who have given a personal mobile number or a household contact number, or who has given a contact of has given the number of a close contact. And of the original cohort, around 75% contacted, and in waves 2 and 2X, more than 70% has actually interviewed. And then some, 1.4% of the original cohort has died, some were too sick or unable to respond, some had emigrated, and only around 1.5% actually refused to be interviewed. So the question would be whether we will be able to track the remaining people later on if we were to do field data collection. So I think Dr. Ravi already mentioned this. We have received positive feedback from participants by mail as well as when we were doing the telephone interviews. And also in a pilot study was done to check if these participants can be relocated, and the results of the study was also looking positive. So there we are confident that most of the original SLHAS participants can be tracked in a potential next round of field data collection. So I think in the later sessions you will get an idea of in greater detail how this data can be used and what are the other innovations of the SLHAS study design. Thank you.